In Brazil, for every 1,000 children born alive, 13 die before they turn 5 years old. Approximately 50% of these deaths are related to causes treated in primary healthcare, such as pneumonia and infectious intestinal diseases. Primary healthcare services in Brazil must attend to the population's main health needs. This includes delivering clinical care, such as consultations, in addition to organizing health promotion and disease prevention actions. The expansion in coverage of primary care increased the population's access to health services and has contributed to the reduction of child mortality rates. However, improving the quality of primary care services can further reduce the chance of children dying before turning 5. In fact, our studies here at SIDAX predicted that we can achieve a 41% reduction in under 5 mortality in Brazil when we improve the quality of primary health care. But how can we measure the impact of the quality of primary care on child mortality? Traditionally, studies assessing primary care look at its components in isolation, focusing, for example, on prenatal care or human resources. But our objective was to understand how all primary healthcare components interact and jointly affect child mortality. And this was our journey. We started by defining the components of primary healthcare and developed a model to understand their relationship with mortality in children under 5 years old. When opening the black box of primary care, we identified 5 building blocks, which represent the structuring components for primary healthcare, and 3 clusters of maternal and child healthcare services. The quality of these clusters of health services is influenced by the quality of the building blocks and, in turn, directly affects under 5 mortality. The building blocks are human resources, inputs for primary healthcare, infrastructure of primary care units, planning and organization of the health team's work processes, and the system of reference and regulation. The clusters of maternal and child healthcare services are prenatal care, child health care, and infrastructure for immunization activities. In addition, we included in our model individual factors, such as the baby's weight at birth and the mother's educational level, because we know they influence child mortality. Each of these components covers a series of indicators that detail actions or inputs under assessment. Next, we measure the effect of the building blocks on maternal and child health services in order to determine the impact of the set of primary healthcare components on child mortality. These analyses were performed using different approaches, which included Bayesian models and predictive models that simulated hundreds of scenarios. All this work was only possible thanks to the cohort of 100 million Brazilians. We used its data alongside data from the PMAC, the National Program to Improve Access and Quality of Primary Care, to link individual information to information from health services. The main results of this study show that substantial improvements in the quality of planning and organization of health teams' work may result in a reduction of more than 5% in child mortality. And that is already a great impact if we consider that it is just one of the components of primary care. Another important result is that when we simulate a significant improvement in the quality of all of the building blocks at the same time, we predict an even greater reduction in child mortality, 41%. Our analyses were replicated in different groups of municipalities, and the results show even larger effects in the most vulnerable of these. Our primary healthcare model can be applied in other low and middle income countries and adapted for other health outcomes, such as maternal mortality. In addition, this model allows managers to identify which facets of primary healthcare need to be developed to expand its effects in improving children's health.